Nursing law, legal and ethical issues, and end of life. Introduction. Throughout this PowerPoint, we will discuss the purpose and scope of the Nurse Practice Act and its role in defining responsibilities and boundaries. Identify key ethical concepts such as autonomy, beneficence, non-maleficence, justice, and their relevance in end-of-life decision-making. Discuss legal documents and decisions such as DNR orders, informed consent, and advance directives. Evaluate case scenarios involving patient autonomy, religious beliefs, and moral conflicts in end-of-life care. Discuss the ability to recognize the nurse's duty to advocate for patients while maintaining legal and ethical boundaries. Utilize frameworks and ethics committees to resolve complex end-of-life care conflicts responsibly. Ethical values guide nurses' decisions, actions, and the outcome of care. Nursing practice is regulated, ensuring nurses work within legal responsibilities and boundaries. Patients have the right to make their own choices, be protected from harm, and receive beneficial care. Nurses must act fairly, avoid causing harm, and often navigate moral conflicts, such as honoring a patient's refusal of life-saving treatment. Ethical competence helps nurses balance personal values, professional duties, and legal standards. Strong ethical and legal awareness supports safe, trustworthy practice, while failing to uphold these standards risks patients' harm, violates scope of practice, and may lead to disciplinary action. When a patient is near the end of life and can't communicate, prior conversations or documents such as advanced care plan, living will, or DNR order guide decision-making. Nurses and the healthcare team must respect and follow these wishes to uphold autonomy and reduce uncertainty. When decisions must be made for the patient, providers use substituted judgment to choose what the patient would have wanted, or best interest reasoning when wishes are unknown. Nurses can reflect by asking, what would this patient have wanted? Will treatment provide meaningful quality time or only prolonged discomfort? And are cultural, spiritual, and personal values being honored? During end-of-life care, nurses facilitate discussions with patients, families, and the care team, clarify care goals and symptoms management, and document and advocate for the patient's wishes and help families understand available options. Foundation of nursing law and ethics. The Nurse Practice Act provides state-specific guidelines that define nursing roles and protect the public's health, safety, and quality of care by ensuring patients receive care from qualified nurses. State Board of Nursing regulate practice, set education and licensing standards, and discipline unsafe conduct. These laws help nurses understand their scope of practice and prevent them from working beyond their level of competence. The Nurse Practice Act defines each nurse's scope of practice. RNs perform full assessments, interpret data, make nursing diagnoses, and develop, implement, and evaluate care plans. They provide teaching and delegate tasks appropriately. LPNs do not perform independent assessments or nursing diagnoses. They can contribute to care plans, and LPNs cannot IV push certain meds or start blood. Ethics is a system of moral principles that shape behavior. In healthcare, it provides a framework for determining right and wrong actions, interventions, and decisions. Ethics guides nurses in addressing issues of patients' rights, safety, and professional responsibility, helping them practice safely and within legal and professional boundaries. It forms the foundation of nursing values, compassion, dignity, respect, and advocacy. By upholding ethical principles, nurses strengthen trust, support effective advocacy, and protect both patients and themselves from harm. Nurses must understand the four principles of biomedical ethics. Autonomy means respecting a patient's right to make their own decisions, such as choosing to stop chemotherapy. Beneficence is an acting in the patient's best interest, for example, comforting a stressed patient. Non-maleficence means do no harm, like double-checking a medication close to prevent an overdose. Justice involves treating patients fairly and ensuring equal access to care regardless of age, background, or insurance status. Informed consent is the process of explaining a proposed procedure, including its risks, benefits, alternatives, and the consequences of refusal, so patients can make autonomous decisions. It is grounded in legal precedent that it protects a patient's right to decide what happens to their body. Proper informed consent safeguards both patients and providers by documentation, informed choices, while failure to obtain it can lead to legal consequences, ethical violations, and loss of trust. The nurses had to intervene because in scenario one, it was an incomplete disclosure of risk and alternatives, and scenario two had a cultural or language barrier in the consent process. End of life care principles. Palliative care is for patients with serious illnesses who have more than 6 months to live, focusing on quality of life through symptom management, stress relief, and coordinated care. It can be provided alongside curative treatment. Hospice care is for patients nearing end of life with an estimated life expectancy of less than 6 months, with treatment no longer prolongs life or the patient chooses comfort only care. Hospice provides symptom relief and emotional and spiritual support for both patients and families. Both palliative and hospice care prioritize comfort and support. A ventilator helps a person breathe when they cannot do so effectively on their own. CPR is an emergency procedure used to restart the heart and breathing after cardiac arrest. Feeding tubes provide nutrition and fluids when someone cannot eat or drink independently. These interventions are considered or for critically ill patients, but may be inappropriate when their burdens outweigh their benefits. A DNR is a legal document signed by a physician stating that CPR, including chest compressions, shocks, and ventilations, should not be performed if the patient's heart or breathing stops. It supports patient autonomy by allowing them to control their medical decisions. A DNR tattoo may reflect a patient's wishes but does not replace a legal DNR form. Written DNR includes patient details, physician signature, and witness. Tattoos may not reflect current wishes and can have alternate meanings. Always follow the official written DNR. A treatment is medically futile if it cannot provide meaningful benefit. Physiological futility occurs when an intervention cannot achieve its intended function. Quantitative futility refers to treatments with a very low chance of success. Qualitative futility is when a benefit is too minimal to meaningfully improve a patient's condition. When disagreements arise between the care team and the patient or surrogate, the case should go through hospital's ethics committee to a fair review respecting both patient's rights and physician integrity. Clear communication helps prevent and resolve conflicts using structured meetings, plain language, confirmation of patient's values, and through documentation. If a treatment is deemed futile and no agreement is reached, care transfer may be necessary, with early communication to keep the family and surrogate informed. Patient autonomy and decision making. Informed consent is when a patient receives clear and complete information about their treatment. Voluntary decision making is when a patient makes their own decision. Decision making capacity is when a patient is able to cognitively make their own decisions. And right to refuse is when the patient can refuse any treatment. Every individual has the right to make decisions about the type of medical care they wish to receive, and those decisions must be respected. Respect for patient autonomy is a cornerstone of medical ethics. The principle underscores the physician's duty to uphold the patient's right to self-determination even when the patient is no longer capable of making decisions independently. One key way to honor this right is through the appropriate use of advance directives. Living wills and advance directives are legal documents specifying the medical treatments you want if you cannot decide for yourself. They guide healthcare professionals and caregivers to honor your preferences. Advance directives are important for adults of all ages, as unexpected medical events can occur anytime. When appointing a healthcare agent, choose someone who meets legal requirements, is not part of your care team, and can discuss and make decisions reflecting your values and advocate for your wishes if disagreements arise. Physicians may sometimes believe that the decisions made by a patient's family members are not in the patient's best interest. In situations where conflicts arise between the intensive care team and the family, support from institutional ethics committees or the courts may be requested to help resolve this disagreement. Every person has the right to make informed healthcare decisions, and professionals should not impose their beliefs. Respecting a patient's refusal of treatment honors their independence. Doctors should ensure the patient understands their conditions, treatment, and risk, and discuss concerns calmly to understand values and reasons. They should address factors like pain, fear, confusion, cultural beliefs, anxiety, or depression. If disagreements persist, the doctor's role is to support a well-informed decision, not to pressure the patient. Physicians have a responsibility to communicate honestly and sensitively with dying patients about their prognosis and the potential consequences of their illness. They should provide as much accurate information as the patient wishes to receive while maintaining compassion and respect for the patient's emotional needs. Special ethical dilemmas. Jehovah's Witnesses believe God requires them to abstain from blood, so knowingly accepting a transfusion is a serious sin that can affect their standing in their faith. Many carry advance directives refusing blood and releasing providers from liability. Most physicians view respecting this choice as a part of honoring patient autonomy even in life-threatening situations. Incarcerated individuals retain the right to health care, and denying necessary treatment can be considered cruel and unusual punishment. Legal cases affirm three key points. Access to medical care, care is prescribed by qualified professionals, and treatment based on independent medical judgment. EMTALA applies to all patients, including those incarcerated. Patient-physician confidentiality and HIPAA protections remain fundamental. EMTALA is a federal law requiring hospitals to provide stabilizing emergency care, and it overrides state abortion restrictions when an abortion is needed to stabilize a patient, even if it falls outside of state-specific exceptions. All current states' bans include exceptions to prevent death or serious harm. For example, Florida permits abortion when there is a serious risk of substantial, irreversible impairment of a major bodily function. Certain state abortion laws explicitly state that treating ectopic pregnancies and managing pregnancy loss is not considered a criminal act. While many of these states permit the removal of a deceased fetus or embryo, they often do not clearly allow for general miscarriage care. As a result, individuals experiencing a miscarriage may be denied medical treatment if fetal cardiac activity is still detectable. Disagreements between patients, families, and clinicians can occur, especially when religious or cultural values differ. These conflicts often reflect family efforts to support a loved one with unfamiliar medical providers. Religion and spirituality frequently influence healthcare decisions, but providers may sometimes overlook these beliefs during complex care planning. The difference between euthanasia and assisted suicide is who performs the final act. In assisted suicide, the patient takes the final step, often use prescribed medication, while euthanasia is intentionally performed to end a patient's life at their informed request to relieve suffering. Both fall under assisted death. Global bioethics provide guidelines on brain death, euthanasia, and assisted suicide, highlighting the need for scientific literacy and ethical reasoning. Assisted suicide occurs with medical support, but the patient carries out the act. Euthanasia deliberately ends a patient's life to relieve suffering, carried out with the patient's informed, voluntary, and uncoerced consent, respecting their autonomy. It ensures a painless death, typically using high-potency analgesics, muscle relaxants, or anesthetics. Euthanasia is considered only for terminal illness and irreversible prognosis, profound suffering, loss of dignity, and declining quality of life. Devaluation of life is when suicide and euthanasia are seen by some as diminishing the inherent value of human life. The slippery slope is when legalizing euthanasia may gradually erode safeguards, leading to broader and potentially unethical applications. Pain can be alleviated by advances in palliative care, and modern therapeutics increasingly allow for adequate pain and symptom management without hastening death. Physician integrity and patient trust is the involvement in intentionally ending life that may compromise a physician's ethical commitment to heal and could weaken the trust patients place in healthcare providers. While physicians are generally expected to preserve life, this duty does not extend to doing so at the cost of patients' dignity or when it results in excessive harm or suffering. The ethical and legal principles of autonomy grants competent individuals the right to make private, personal decisions about their medical care, including choices regarding end-of-life options. Mandatory reporting laws. Covered entities can disclose protected health information to law enforcement when required by law, such as reporting certain injuries. Healthcare providers must report suspected child or elder abuse or neglect, even if not fully certain, as these vulnerable groups may be unable to protect themselves. Respecting a client's autonomy can conflict with the duty to maintain confidentiality. However, when someone is abused, neglected, or at risk, protecting them, often via mandatory reporting, takes precedence. This is especially important at the end of life, where vulnerability increases due to cognitive decline, confusion, or dependence. Patients with substance use disorders are at high risk for undertreated pain, often because clinicians fear relapse, suspected drug seeking, or feel unprepared for complex cases. Pain is subjective, and pain is whatever the patient is experiencing, meaning clinicians must respect patients' self-reports. This applies to all patients with true pain, including those with sickle cell disease. Gender-affirming care supports people's social, emotional, and medical needs to live in line with their gender identity. Laws may limit certain treatments, especially for minors, creating challenges for patients and providers. Doctors must follow these rules while treating patients with respect, offering clear information, safe legal options, and emotional support. Even when some treatments aren't available, counseling, general care, and referrals remain possible. The experience of dying alone became a harsh reality for many during the pandemic, as healthcare facilities in the US and beyond implemented strict no-visitor policies to limit the spread of the virus. As a result, countless individuals in hospitals and nursing homes spent their final hours in isolation without the presence of comfort of loved ones.
Ethical conflicts in pediatrics. While parents have the authority to make decisions for their children, healthcare providers must ensure that children receive necessary medical care. Parents have the right to make healthcare decisions for their children, but the question is, shouldn't minors have the right to make decisions in the best interest of their health? This would be considered birth control or even optional vaccinations. In 2014, 17-year-old Cassandra C. was diagnosed with Hodgkin's lymphoma and refused chemotherapy. The court ruled she was not legally allowed to refuse life-saving treatment. Cassandra was forced to undergo chemotherapy because refusal amounted to medical neglect. Confidential care for adolescents is vital because it promotes honest communication and access to care about sensitive health issues. Lack of confidentiality can be a barrier to receiving care due to fear of judgment, shame, or even punishment from parents. This can cause serious health issues from an untreated UTI, STD, interpersonal violence, or substance use, and more. Parents and healthcare providers can have discussions about the importance of confidentiality with parents as it builds trust, provides a safe environment, and gives adolescents ownership over their life. When confidentiality is breached, it can be hard to regain that trust with a patient, and it can lead to a distrust in healthcare providers and even more harm to a patient's health by not seeking future treatment. The idea of futility when treatment no longer benefits the patient must be understood. Disagreements between parents and clinicians about what is futile can lead to ethical, legal, and emotional concerns. When a child has somewhat predictable preferences or older children with capacity, decision makers may try to infer what the child would have chosen, which is called substituted judgment. With very young or incapacitated children, or when preferences are unknown, decisions generally fall back to what is judged as the child's best interest. Ethical conflicts and emergencies and disasters. The allocation of sacred resources such as ventilators, ICU beds, and advanced treatments is something that the healthcare system faces when overwhelmed, such as in a disaster or a public health crisis. The allocation should rely on objective criteria that includes the urgency of illness, likelihood of benefit, duration and quality of recovery, as well as the resources needed to achieve such recovery. Unethical factors should not be taken into consideration, such as the ability to pay. After COVID-19, this was shifted to a crisis standard to use a triage protocol before the disaster struck. In an emergency situation, there is an ethical conflict between respecting patient autonomy and prioritizing emergency survival. Autonomy allows for patients to have the right to make decisions about their care, which includes choosing, refusing consent after understanding the risks, benefits, and alternatives. In acute scenarios, if a patient is incapacitated, staff must act with implied consent as if the patient would agree to life-saving treatment. The conflict lies between the duty to save lives and do no harm while respecting autonomy. Triage systems like START, Simple Triage and Rapid Treatment, and SALT, Sort, Assess, Life-Saving Interventions, Treat, and Transport, prioritize patients based on injury severity and expected outcomes with limited resources. The triage categories are green for minor, walking wounded and can wait a few hours for treatment, yellow, delayed, serious but stable, red, immediate with life-threatening injuries, black, expectant or deceased, unable to survive with available resources or already deceased. In SALT, expectant is gray and deceased remains black. The goal of triage is to save the greatest numbers of lives, which can require extremely difficult decisions. Care may be redirected away from an expectant patient if those resources could save several others with better chances of survival. This may mean not starting CPR or mechanical ventilation on a gravely injured patient when doing so would consume limited resources needed elsewhere. The ethical tension is that while every patient deserves care in mass casualty situations, the duty to maximize overall survival requires prioritizing treatments where they would do the most good, even when it means withholding or delaying care from those unlikely to survive. During disasters and mass casualty events, nurses and healthcare providers face increased legal and document responsibilities. Accurate, thorough documentation of triage decisions, care given or withheld, patient status, and resource limitations is essential for transparency, continuation of care, and legal protection. Even in crisis conditions, regulations like EMTALA still apply, and providers must act within good faith as well as their scope of practice. Legal protections such as state and federal immunity for emergency responders can reduce liability, but only when providers follow formal emergency declarations, proper credentials, and organizational protocols. When placed in a disaster situation, nurses must engage in triage, which essentially means choosing who receives care and who does not, which causes them to face profound psychological burden. These choices can trigger moral distress from conflicts held in professional or personal ethics. This is a case study on triage protocol. Throughout this scenario, think about which patient you would triage in each category. Patient A, we would triage as yellow, needs treatment for the bleeding and wound management, but is stable. Patient B, we would triage as black because of the absence of a pulse and severe head trauma. Patient C would be triaged as immediate because of the respiratory compromise and low oxygenation status. Patient D, we would triage as yellow because it is not a life-threatening injury. Patient E, we would triage as red due to the unstable vital signs and suspected internal bleeding. Practical challenges and nursing ethics. Higher patient-to-nurse ratios often prevent staff from providing the level of care they believe is right, leading to moral distress. Shortages increase legal and ethical risks, including compromised patient safety, potential medical errors, and increased liability. Patient advocacy includes promoting patient safety and quality care. However, related to abortion care under restrictive laws like Texas SB 8, nurses may encounter legal uncertainty regarding aiding or abetting liability. When a patient's documented or clearly expressed wishes conflict with a family member's desires, nurses must carefully navigate the tension between patient autonomy and family dynamics. Research shows that families often become emotionally distressed, overwhelmed, or in denial, which can lead them to push for treatments that the patient explicitly denied. Good documentation must be clear, objective, timing, and secure. Delayed charting increases the risk of errors or missing details and may be viewed as unreliable in legal situations. For nurses, ethical committees offer a structured avenue to navigate conflicts, clarify values, improve communication with physicians and administrators or families, and ensure that institutional policies support ethical practice while protecting patient rights and professional integrity. Case studies and scenarios. As you read this case scenario, think through a few discussion points, such as how does implied consent apply in this situation? What legal protections exist for emergency responders acting in good faith? How would you communicate with the families or surrogates once available? And what are the potential psychological impacts on the healthcare team making these life or death decisions? Throughout scenario 2, I want you to consider how implied consent applies when a patient is unconscious but displays a visible indication of refusal, what alternatives exist for bloodless management, and what legal protections or liabilities exist for providers acting based on visible directives versus unknown wishes. For our last case scenario, I want you to consider how can nurses support patient autonomy and relieve suffering within legal constraints, what palliative care or comfort-focused interventions can be maximized when euthanasia is not an option, how should nurses handle moral distress or ethical conflict arising from a patient's request versus the law, and how can clear communication and documentation protect both the patient's rights and the healthcare team legally.
Conclusion. The key points I hoped you learned through this PowerPoint is legal and ethical awareness, law and ethics, end-of-life care, special ethical dilemmas, pediatric and emergency ethics, and practical nursing challenges.